everyone to our webinar series, and thank you very much for attending this afternoon's webinar. So this is the second webinar in our 2015 webinar series, and today's webinar will focus on the views of the primary care nurse practitioners and primary care physicians on a variety of issues, but mostly focusing in on career recommendations of these two clinician groups. Now, some of you may have been with us during last fall when our webinar series focused all fall on the rural workforce. We had presentations about physicians, dentists, nurse practitioners, and physician's assistants, and we summarized all of that webinar content in a ending a piece on our website back in December, and we have video recordings and much of the content from those prior webinars on the rural workforce. Should you be interested in obtaining those, check our website, or if you have any difficulty, check in with Christy. Now, before we begin today, I want to take a few moments to make some announcements. First, in case you don't know, we have released the fourth quarter 2014 estimates of registered nurse employment in the United States. Now, as some of you may know, we are now able to provide estimates of certain characteristics of the RN workforce on a quarterly basis, which allows us to see how the workforce is changing and what's happening in employment growth and other factors only 2 or 3 months past the time when these data were actually recorded. So we're able to provide a much faster picture of current events in the nurse employment in the United States. So I invite you to take a look at our website. We just posted the fourth quarter of 2014, I think last week. Second, I'd like to mention that we're now sending out a monthly newsletter called the Center Point that details recent research, information, and news about our center and the workforce community in larger ways. If you haven't received the Center Point and you'd like to, please let Christy Friedman, the center's program director and the editor of Center Point, let her know, and she'll get you added to the list. Finally, I want to mention that the Center for Interdisciplinary Health Workforce Studies is partnering with the National Forum of State Nursing Workforce Centers. This forum represents roughly 36 state-level nursing workforce centers, and we're working with the forum to jointly organize a nursing workforce conference. It's called State of the Nursing Workforce in an Era of Healthcare Reform, Data, Trends, and New Collaborations. Now, this conference is going to be held for 3 days starting June 10th through 12th in Denver, Colorado. Well, we anticipate this conference is going to provide a powerful 3-day event that will bring together state-level nursing workforce centers' efforts and their leaders together with the nation's premier researchers in the field of nursing workforce research. We want to share insights, develop key objectives, look at collaborations, strategic planning to strengthen our nation's nursing workforce as we move through this very dynamic era of health reform. Now, we have concluded the call for abstracts, so if you didn't get one in, I'm sorry you missed this time, but perhaps later down the road if we are able to pull this conference together again. But registration is still open, and we hope you will join us to be in Denver in June. And again, if you go to our website, you can find more information there. So now, I'd like to move into today's webinar, but before I introduce our speaker, Catherine DesRoches, I'll just signal to everyone that after Kate gives her presentation, we'll have at least 15, 20 minutes perhaps for discussion and fielding any questions that you may have for Kate. Feel free to type any questions you have in the area designated for questions on your menu bar, and we'll get to as many of these questions as we can. We are recording the webinar today, and we'll have it posted on our website at healthworkforcestudies healthworkforcestudies.com. That's healthworkforcestudies.com. As I said earlier, we posted all of our previous webinars on our website, so you can go back and listen to those in case you are interested. You can also find presentation slides posted with the event calendar as presenters make their slides available to us. All right, so today our presentation will be given by Dr. Catherine DesRoches, Kate, of Mathematica Policy Research. I call her Kate because I've been working with her for about 15 years, and I want to disclose that we've worked together, and I've actually worked on this project that Kate will be presenting today. But Kate has been involved in, oh my gosh, more than 85 national and international surveys on a variety of health policy and public health issues. So a very seasoned, very accomplished surveyor, both nationally and internationally. Now, before joining Mathematica in Boston, the Mathematica headquarters or offices there, before that, Kate spent 10 years as a faculty member and researcher at the Mongan Institute for Health Policy and the Harvard Medical School and the Harvard School of Public Health. She has led or collaborated on national studies of nurse practitioners, registered nurses, physicians, healthcare executives, the public, and many other populations. Now, these studies have addressed, among other topics, the role of nurse practitioners providing primary care, a variety of nursing workforce issues, clinicians' adoption and use of health information technology. And you'll see Kate in the New England Journal of Health Affairs with multiple publications around hospitals and physicians' adoption of HIT. Physicians' responses to the changing healthcare system, physician-industry relationships, and access to and satisfaction with healthcare. In addition to all that, Kate has extensive experience leading and managing interdisciplinary research on healthcare topics using a wide range of research methods and data. Her work has received support from the Office of the National Coordinator for Health Information Technology, which is part of the HHS. She's received support from the Robert Wood Johnson Foundation, the Gordon and Betty Moore Foundation, the National Institutes of Health Office of Research Integrity, and of course the Agency for Healthcare Research and Quality. Kate received her Doctorate of Public Health from Columbia University, and today she's going to be talking about some recent research that focuses on the perceptions of nurse practitioners and physicians providing primary care in the U.S. So, Kate, with that introduction, I'm going to switch things over to you and let you take control of our webinar. So again, Kate, thank you very much for joining us.
Thank you, Pete, for that terrific introduction. Let me just make sure that, so I am showing my screen. And, okay, can everyone see the slides? Pete, are we good?
Yep. We're good.
Okay, so thank you, Pete, for that terrific introduction. I want to take just a minute. This project that I'll be talking to you about today was a team sport, as always, and it included Pete, Karen Donnellan, who's at Massachusetts General Hospital in the Mongan Institute for Health Policy, and Bob Dittis, your own Bob Dittis at Vanderbilt University. The project was funded by a kind of coalition of funders, the Gordon and Betty Moore Foundation, J&J's Campaign for Nursing's Future, and the Robert Wood Johnson Foundation. And just noting here, I have no relevant conflicts of interest to disclose. So I thought I would start today with an overview of the project because this survey work was situated in a larger research project. So I'll give you sort of the overview, what the goals of the project were, and some context before we get into the findings. So this project involved two complementary studies. The first piece of this work was actually an empirical assessment of NP-provided care, and this part of the project used Medicare claims data to look at NP-provided care compared to primary care physician-provided care. So it was really kind of the first look at, could you use Medicare data to do this, and what would you find? So that was the first piece. And then the second, which I'll be talking about today, were these parallel national sample surveys of primary care nurse practitioners and primary care physicians. So they're national level analyses, and they're really, both pieces of the project were focused on a comparative assessment of nurse practitioners and physicians. We had some very specific goals in mind when we put this project together. First, we wanted to generate results that could really be used to help guide workforce policy development. We also wanted the results to help stimulate constructive policy discussion. So we wanted to provide some data that people could go back to rather than what was happening at the time, which was that sort of physicians were often on one side of this issue and nurse practitioners were on the other. And what we really wanted to do was provide data for people to be able to make data-driven decisions. And then finally, we wanted to increase mutual understanding between these two groups of professionals. So to try to help break down some of the silos that can occur. So why, at the time, did we have this interest in expanding NP's role in providing primary care? And there's really three major reasons. The first is just access. So we know millions of Americans lack access to a primary care provider. Many live in primary care shortage areas. We know that there's a projected primary care physician shortage. There's some discussion about how big or small that shortage will be, but I don't think there's a lot of argument about whether there will be a shortage or not. And then finally, there are a lot of policy things going on right now out of the related to the ACA, and we're seeing millions of Americans obtaining health insurance. So people who didn't have the option before now suddenly have the option. And there's estimates that this is going to add between 15 and 24 million primary care visits in the next 4 years. So these three things coming together is creating a lot of interest in how are we going to meet this demand, this growing demand for primary care. Now, the preponderance of evidence shows that NPs provide care that is of similar or better quality than physicians. Now, many of these studies are a little bit old, and they were primarily conducted in either single site settings or they were focused on a specific illness. But there is a lot of evidence out there that shows that NP care is similar or better. There are also some government investments that are happening in the NP workforce. Some of these were part of the ACA. They haven't been funded at the level that I think the authors of the bill hoped, but there is this government investment in the workforce. And then finally, on the market side, there are all these new models of care. Primary things like patient-centered medical homes, ACOs and things like that are relying on NPs to provide care even for the Medicare population, and this is really driving a lot of interest in understanding how NPs are fitting into these kind of team-based care models. Now, all of this, these earlier slides make it sound like, oh yes, everyone thinks NPs should be playing this larger role, and we're all on board, and we're all moving forward in this direction. But there was a considerable amount of controversy. So, as I'm sure most of the people on this call know, in 2011, the IOM report on the future of nursing called for a number of substantial changes, including, allowing NPs to be recognized in independent practice by private insurers and by state boards of state law, also calling for NPs to be leaders of patient-centered medical homes, as well as other things like admitting privileges and equal pay for equal service. And all of these things in the report generated an enormous amount of pushback from physician organizations. There was just a lot of heated debate over, are these clinicians prepared, are they educationally prepared to take on these kinds of roles, and what's the value of NP-provided care versus the value of care provided by a physician. But at the time, there was really very little data to fall back on. So there was a lot of arguing, and there was a lot of sort of hot air getting blown around, but there was very little data from on-the-ground clinicians. So into that breach, we stepped into that breach and started working on a survey that would allow for comparative reports by primary care physicians and primary care nurse practitioners. And this survey, what you see here on the slide are all of the topics that are covered in the survey. Now, I'm going to just be talking about the two that are in red, the workforce supply and career satisfaction, but there's a lot more in there, and there are a series of papers that have come out from the survey that provide more information on the other topics. So just quickly to go through the methods, the survey was fielded from November 2011 to April 2012. So it's a couple of years old now, although we have just wrapped up the field period for a similar survey of nurse practitioners and physicians working in specialized care settings. So be on the lookout for that data coming out, hopefully by the end of the year. Our study population, as I said, was primary care nurse practitioners and physicians who are providing direct patient care in the U.S. We got our samples. The physician sample came from the AMA master file, and the NP sample is a similar file that Medical Marketing Services keeps. So we purchased the sample from them. We collected the data through, it was a self-administered mail survey. We did pay them. You can see here are our sample sizes. They're roughly 500 in each group, PC, NPs, and PCPs, and our overall response rate was 61%. So here's our respondent characteristics. And I want to draw your attention to a few differences. These are different populations of clinicians. The primary care nurse practitioners are overwhelmingly female, whereas you see the PCP group they're a little bit more balanced. Our primary care nurse practitioners were also a less diverse group, so they're much more likely to self-report as white as compared to the PCPs. And they're a little older. So this difference is not quite as large as the others, but you can see they're still a little bit of an older population. So for a little bit more context, I want to talk about where they're practicing and how they're practicing. So if you look at the top of this table, you can see that primary care nurse practitioners, they work fewer hours than primary care physicians, and they also see fewer patients during that time. So fewer hours and fewer patients, and not as we expected, they also are paid less. But the other thing I want to point out that's interesting about this slide is the mix of patients that they're seeing. So these percentages here are the percent of their overall revenue that comes from each of these payers. So you can see that when compared to PCPs, primary care nurse practitioners are seeing more Medicaid patients, and they see more patients in this patient payment / other category. So what that is, it's really, those are patients who are paying for their own care. So primarily, that's kind of code language for uninsured. So you can see they're seeing more uninsured patients and more Medicaid patients. And they also see a more diverse patient panel. So 35% of them say that more than a quarter of their patients are African American or Black, compared to 19% of PCPs. And there's a similar difference for Hispanic or Latino patients, and you can see a large difference on the uninsured number. So just to kind of sum up for practice, they work fewer hours and they see fewer patients, but the patients that they are seeing are from more disadvantaged groups. So I'm going to talk for a few minutes about our respondents' perceptions of workforce shortages and their career satisfaction. And eventually what we're going to get to is looking at the correlation between shortages and career satisfaction. But to kind of set the context, I'll give you the overview first. So we asked them about the number of primary care physicians in the U.S. and in their community, and the number of primary care nurse practitioners in the U.S. and in their community. We asked them whether it's greater than the demand, about equal to the demand, or less than the demand. And the first thing that you notice is there's really not a lot of argument about whether there's a shortage of primary care physicians in the U.S. So pretty much everyone agrees that that shortage is there. Where we start to see a difference is when you look at primary care nurse practitioners. So when we asked about that, what the demand is like nationally and what the demand is like in their community, you can see that nurse practitioners are saying, yeah, we see a shortage of primary care nurse practitioners, but many fewer primary care physicians see a shortage of nurse practitioners. And then I'm going to show you a quick couple of slides about satisfaction with job and career, and then we'll get to how these two things combine. So here is satisfaction with current employment. So you can see there's really not that much difference between our two groups. If you combine the somewhat and the varies together, you get, a very, very good majority say that they are satisfied with their current employment. When you look at satisfaction with career, here's where we really notice a difference. So nurse practitioners are very satisfied with being nurse practitioners. They love it. Even if they're not always so happy with their current employment, when you add the somewhat and the varies together, you get over 90% that say they're satisfied with being a nurse practitioner. And the interesting thing is really the end of this scale where you see the vary number. There's a really big difference between the PCP, between the primary care physicians and the primary care nurse practitioners. Now, career recommendations, that's another measure of job satisfaction. So you can ask, of career satisfaction. And what we see when we look at this one is, so first, let's start with the primary care physicians. So we ask them, given what you know about the state of healthcare, would you advise a qualified student to pursue a career as a primary care physician? You can see that 55% of primary care physicians said, yeah, I definitely would, or I probably would. And so did 2/3 of primary care nurse practitioners. So the nurse practitioners are actually more likely to recommend a career as a primary care physician than the primary care physicians themselves. Now, 88% of primary care nurse practitioners would recommend their own career. But the thing that surprised us the most about this data is you can see that primary care physicians would be more likely to recommend a career as a primary care nurse practitioner than to recommend their own career. So we're seeing just serious dissatisfaction among our primary care physicians. Now, when we put them together, so perceptions of shortages and career recommendations, one hypothesis that we had is that physicians and nurse practitioners who see a shortage in their own, in their fields would be more likely to recommend that field to a qualified student. And what you can see here is among the primary care physicians, it really doesn't make that much difference. The dark blue bars are physicians who see a shortage, and the light blue bars are physicians who see no shortage, and you really don't see much of a difference. And the same is true for primary care nurse practitioners. So perception of a shortage is not affecting the kinds of career recommendations that these clinicians would make. However, if you look at satisfaction with job and career, I'm going to just draw your attention to the bar that's furthest to the right to show that these are primary care physicians, and it's satisfaction with career. So you see 46% are very satisfied, and then we have 35 and 15 who are somewhat or dissatisfied. If you just look at that group, you see that 37% of them would recommend their own career, while 63% would recommend a career as a primary care nurse practitioner. And we see the same pattern if you look at satisfaction with current employment. It's almost the same. So for PCPs, for primary care physicians, their career and job satisfaction is affecting the types of career recommendations that they would make. For nurse practitioners, you don't see that same pattern. I'm not showing the data here, but what I'll tell you is that for nurse practitioners who are satisfied, who are not very satisfied, they're only somewhat satisfied or they're dissatisfied with their current employment, that makes absolutely no difference in whether they would recommend their career. People who are dissatisfied are equally likely as people who are very satisfied. And you see the same thing when you look at their satisfaction with their career. So one of the other things, so I'll just stop for a minute here and just recap. So what we've seen so far is perceptions of a shortage doesn't make a difference in terms of the career recommendations that people will make. Job and career satisfaction does make a difference, but only for primary care physicians. Now, one of the other things we looked at in this survey was ratings of their workplace. And the hypothesis here is that people who work in places where they don't feel that they have a lot of autonomy, so they don't have an opportunity to influence decisions, will be less likely to recommend that career to others. So this is just a first look at their ratings of their workplace. So starting on the left, you see PCNPs compared to PCPs are less likely to say that their workplace is excellent or very good for opportunities to influence decisions about how the workplace is organized. Physicians appear to be more satisfied with that. And you see the same with opportunities to influence decisions about patient care, where physicians appear to be operating with more autonomy and more decision-making power than the nurse practitioners. So now we cross workplace ratings with career recommendations, and you can see that among clinicians rating opportunities to influence workplace organization as fair or poor, that's who we're looking at in this slide. That's our base. And the dark blue bars are primary care physicians, and yes, and the light, no, I'm sorry, I have this, I apologize, the label on this is backwards. So the dark blue bars are primary care nurse practitioners, and the light bars are primary care physicians. So what you can see when you look at this is even among those who are rating their workplace organization as fair or poor, primary care nurse practitioners are still more likely than primary care physicians to recommend both a career as a PCP and a career as a PCNP. And then we have the same problem on this slide. So the dark blue is the primary care nurse practitioners, and the light blue is the light blue are the primary care physicians. And you see the same pattern. Still, the PCNPs, the primary care nurse practitioners, are still more likely to be willing to recommend their own career. So in conclusion, I want to make sure that we leave plenty of time for questions. So we'll run through these, and then I think we'll have plenty of time left over. We thought that these results really raised some surprising issues for policymakers. And among those issues are, even in low autonomy settings, NPs are more likely than PCPs to recommend their own career. So that kind of goes counter to what we think of when we think of career and job satisfaction, that higher autonomy professions are more likely to recommend their own career. And here we're seeing that that's not the case, that the nurse practitioners, even in settings where they think, oh, I really don't have a lot of say over how my work is organized or the care that I provide, they're still more likely than PCPs to recommend their own career. So that was the first surprise. Second, we found that even PCPs who report shortages of primary care clinicians in their own community, though they are still more likely to recommend a career as a primary care nurse practitioner. So typically, if you see a shortage in your profession, and you're generally satisfied with your profession, you would recommend it to others. In this case, we're not seeing that. We're seeing the dissatisfaction with the career seems to be outweighing the perception of the shortage. And then, I didn't show you this data, but we did ask PCPs and NPs what they thought would happen if the supply of NPs increased. And some of the responses that they gave us were things like, my income would, for primary care physicians, they thought, well, my income will decrease. And the work that I do, I'll be replaced by an NP. And those were pretty widely held beliefs, but we're still seeing them willing to recommend this career. So there's a kind of a question here of how do we reconcile this willingness to recommend this career given what primary care physicians think will happen to their own income and their replacement. So those were some surprising issues that we ran across, and I think they have some very significant policy implications. And the first thing that we need to really be thinking about is it's likely that our results are a reflection of primary care physicians' pessimism about the future of primary care medicine. So, primary care physicians come out of school with a significant amount of debt. They have lower incomes in relation to specialists. They work very long hours. There's a lot of, complaints about paperwork and bureaucracy. And in general, the primary care is kind of a devalued specialty in medicine. So they see all of these things happening around them, and it's likely that what we're seeing in these results is a reflection of just this kind of deep pessimism about primary care medicine. So given that deep level of pessimism that we're seeing, it seems to me to be unlikely that adding more slots to primary care training slots is unlikely to solve the problem. If we're continuing to create primary care physicians through training who are then unable to recommend their own career to others, it seems unlikely that just adding more slots is really going to solve the problem. Instead, I would expect that we need more of a multi-pronged approach. So there are traditional solutions to workforce shortages, and many of them were used during the registered nurse shortage. So things like increasing wages, improving the workplace environment, and so those two things together can help to bring more people into the field. But again, as we've discussed, it's unlikely that it's going to be that's going to be the complete solution. Now, part of the solution to the nursing shortage was this J&J campaign for nursing's future, and their explicit goal was to change the perception of nursing, to make it sort of more attractive for very qualified students to want to become nurses, and we may need something like that for primary care physicians. And finally, there are a lot of new models of care out there. And these new models of care are all based around teams, with the goal of the team being that everyone is working at the top of their license. These are designed to increase efficiency and quality and also patient-centeredness, and those types of new models of care may actually result in increased satisfaction for providers. And there is some data out there to suggest that physicians, this is a physician-specific study, that physicians who work in well-functioning teams are much more satisfied with their current job and their career than physicians who are working in more dysfunctional teams. So it's likely that we will need, that we should be measuring physician and nurse practitioner satisfaction in these new models, because that may be a way to sort of redesigning the way care is provided, may be a way to increase satisfaction. So in closing, what I want people to take away from this is that nurse practitioners have lower incomes, they see fewer patients, they report less workplace autonomy, and they still report a much higher magnitude of and degree of satisfaction. So, excuse me, a much higher degree of satisfaction. And what we're seeing that in these career recommendations. And until we figure out a way to increase the satisfaction of primary care physicians, we're unlikely to solve this problem of the workforce shortage. And now I'm ready to take any questions people have.
Thank you very much, Kate. That was a terrific presentation, and I think that you've given us a lot of interesting information to think about and contemplate. We have several questions, but I want to begin personally, as others are thinking through their questions and can write them in. One thing that struck me, and I wonder if you have any thoughts about this. This is going back to the survey of NPs and primary care physicians, and you show that NPs are seeing fewer patients per week. Mm-hmm. And what I'm wondering about is, is this because maybe they are taking more time with each patient? Because also you showed that NPs are more likely to be taking care of patients from vulnerable populations.
Yeah.
So they're spending more time perhaps with patients, and that's why they're seeing fewer visits. But I also noticed that they're working fewer hours.
Right.
And maybe that's it. Or is it maybe some combination? Do you have any insight as to why that may be occurring?
So one of the things I think is influencing that is when we looked at where these nurse practitioners and primary care physicians are employed and how they're compensated, many of the nurse practitioners were compensated on a salaried basis. So they just got they were employed by their organization and they had a straight salary. Whereas the physicians were often were a salary adjusted for performance, or they were in fee-for-service. So what we heard from physicians is, I'm in a practice where I'm pressured to increase my productivity. And the nurse practitioners, because they are employed with a salary, are often not subjected to the same pressure to see more patients per hour. So that can be an organizational that can be kind of a part of it can be this organizational policy. Now, the other thing could be that they are working in settings where again, they're not required to see as many patients per hour because they are seeing these patients from more disadvantaged populations. So that's another possibility. But one of the things that we did hear from, I've presented these findings off and on since they were published, and one of the things we do regularly hear from physicians is, when they get their patient satisfaction or patient experience data back, and they see their own data and they see the data from the nurse practitioners, they sort of feel like, well, my patient satisfaction numbers would look that good if I didn't have to see as many patients as I do. So a lot of it can kind of, I think, boils down to sort of the economics of practice.
Okay, great. Thanks, Kate. I'm going to go ahead and open up our floor for questions. Again, if you don't know who I am, I'm Christy Friedman, the Program Manager for the Center. Excuse me. All right, so let's get started. First question we have, Kate, do you have an idea of what percentage of all U.S. physicians, NPs, and PAs are in primary care?
So I don't have that number off the top of my head. I think that the new HRSA survey of nurse practitioners says that, I don't know, Pete, I'm guessing, I think the new HRSA data has the number for nurse practitioners around 60% in primary care. For physicians, it's much lower than that. And then PAs tend to be in more specialized settings. They are less likely than nurse practitioners to be in primary care settings. But the thing that's tricky about this is even when a nurse practitioner is in a specialty setting, they may be doing more primary care-like work with the specialist's patients. So they may be, it may be that the specialist sees the patient for their diabetes and the nurse practitioner manages the rest of the patient's care. So it's a little bit tricky to untangle those relationships.
Okay, great. And then the second question, why did you not include PAs in your survey? I think maybe you just hit on that, but if you have anything else to elaborate on why you didn't include PAs.
So we have gotten that question many times, and the first, the first answer is that at the time, there was some evidence that suggested that PAs were more likely to be in specialty settings than in primary care. And the other reason is that a lot of this study and the interest in doing this work grew out of the debate around nurse practitioners and physicians. And there isn't that same level of debate around PAs. So PAs are trained through more of a medical model, and physicians don't seem as there doesn't seem to be the two groups don't seem to be at loggerheads the way nurse practitioners and physician associations can be. And because their professional associations were really at loggerheads, our interest was in what's happening with on-the-ground clinicians.
Okay, great. That's understandable. You mentioned a new survey of NPs and physicians providing specialist care. Can you tell us a little more about that survey?
Sure. So that survey has just come out of the field, and we surveyed physicians and nurse practitioners, and Pete is going to jump in and correct me if I'm wrong about this. Surveyed nurse practitioners and physicians working in ICUs, in cardiac ICUs, and emergency medicine. Oh, and trauma. That was the last one. So we don't really have a good handle on the results yet because the data's just come out of the field. We've just come out of the field. But it's sort of a follow-up to this survey. Some similar questions, but also new material to reflect the different settings that these clinicians are working in.
Okay. I have one more question that's two parts. Can you just summarize? Can you summarize the results of the CMS claims data? And then the second part, does the national survey of NPs and MDs support or negate the findings from the CMS study?
Well, I'll answer the second question. Well, no, I guess I'll answer them in order. So what we found in the first, so that work is ongoing, but in the first the first phase of that work was published a couple of months ago in Nursing Outlook. And what we found there is that nurse practitioners so these are nurse practitioners who bill under their own number to Medicare. So that's the only way you can find them in the data set. And what we found there was that nurse practitioners, that the patients that they were seeing seemed to be similar to the patients that primary care physicians were seeing. So in terms of their disease burden, they looked similar. However, they were a younger population. The NP patients were younger. They were more likely to have qualified for Medicaid due to a disability. And they were more likely to be dually eligible for Medicaid and Medicare. So they're younger, they're poorer because the dual eligibility is a marker for poverty, and they're more likely to be disabled. We also found that the nurse practitioners who were billing under their own number were significantly more likely to be in primary care shortage areas. So that's the kind of summing up of those of that first set of findings. And they track pretty nicely with what we learned in the survey. So, you know, early on in the results, I'm just going to flip back up to the, oh, maybe I can't. No, I guess I'm not the presenter anymore. Some of the early slides showed that the nurse practitioners were telling us, you know, more of their revenue came from Medicaid than physicians. So if the physicians told us a certain percentage and the nurse practitioners, their percentage from Medicaid was higher and their percentage of uninsured patients was much higher. So it tracks pretty nicely.
Okay, great. I have a question here that why was the MMS database used for NPs when it has been shown that it can be all that not reliable?
Yes, so we did discover that. The problem with surveying nurse practitioners is that there aren't good data sources available for them the way that the master file is available for physicians. There's, you know, when HRSA does their survey, they spend quite a bit of time actually building their own sample ahead of time through the boards of nursing, and that is a very time-consuming and expensive process. So we went with the MMS file because from our sort of early research, it seemed like it was the best of the bunch, knowing that the bunch was not all that good. And then what we did was use a screener at the beginning of the survey that confirmed that they were a nurse practitioner, confirmed that they were still practicing in direct patient care, and confirmed that they were working in a primary care setting. And we did have more ineligibles from that in the nurse practitioner sample than we had in the primary care physician sample. So I agree that the MMS is not a great data file, but at the same time it was kind of the best of a sort of moderately bad bunch.
Okay, great. This is similar to what we asked before, but I think you made the comparison more of NPs to physicians and PAs to physicians. But are the roles of NPs and PAs considered broadly exchangeable by labor economists?
Well, I'm going to punt that question to our economist, Dr. Pierre Bierhaus. But I will say that among physicians, in some of the qualitative work that we've been doing, among physicians, they tend to see the role of the NP and the role of the PA as more interchangeable.
Yeah, I think that's a deep question, because I think it raises questions of perspective and philosophy. I think many nurse practitioners would say, no, I'm not like a physician's assistant. I do other things and have a different perspective on the patient, their interactions with their environment, their interrelationships with family and others. That puts me into a more of a holistic view of human beings and their health. And that incorporates maybe cure, but also carry, and things of that kind. I'm sort of just paraphrasing that perspective. A physician's assistant, and I'm not a physician's assistant, so I can certainly be educated on this, is likely, though, to have a different perspective on their role. That's not to say it's better or worse or anything like that. So I think from one sense, if you ask the two different groups, I would be surprised if they would agree that they are fungible or substitutable. At the same time, they both do certain clinical activities in the same procedures, probably very similar in terms of their outcomes, etc. So their activity oftentimes could be or are substitutable or fungible. Perspectives are different. Now that's a lot, and maybe a payer or a policymaker just doesn't want to get involved in all that. They're looking at who's available, how quickly can you educate them, and what can they do, and will they work in a shortage area. And I think it's a whole different set of perspectives than what I just covered. So I'm not trying to escape the question. I'm just saying I think it's a deep question that requires a deeper sort of analysis that incorporates the multiple perspectives. How's that one, Kate?
That was good, Pete. Very good.
We had another one, which was, did you consider the influence of scope of practice in either your CMS studies or the National Survey of Primary Care Nurse Practitioners and Primary Care Physicians?
That's a great question, and the short answer is yes, we did consider that. The long answer is that it's much trickier than it seems to do it. So, it's very tempting with scope of practice, and I think the Pearson report used to do this, where they kind of divided states into full practice autonomy, so no restrictions on diagnosing, and prescribing, and then a kind of this mixed group where there are restrictions on prescribing, but not necessarily restrictions on diagnosing and treating. And then the third group, which is a kind of much more restrictive, where NPs aren't allowed to practice independently. But what you find when you dig into those groups is just a significant amount of variation within each of the groups. So in the most restrictive, there are states that range from, well, we need to have some kind of a written agreement with a physician that just basically says this physician supervises this nurse practitioner, down to states where the physician has to co-sign the orders. So it's tricky to kind of lump the states together, but it's very hard to have enough sample to include each state independently in your analysis. So we initially went with the 3 buckets. So we had a very restrictive, moderately restrictive, and not restrictive. And we used that variable both in the CMS analysis and in the survey analysis, and it didn't really make a difference. And we were very puzzled by that. So we went back and we looked again, and that's when we noticed that we noticed a tremendous amount of variation. Then we started talking to nurse practitioners and physicians in different settings who told us things like, well, it's really my organization that limits what I can do. It's not the state that limits what I can do. Or, or like we discovered, talking with someone who practices in Florida, where NPs are not allowed to prescribe controlled substances. And they had an arrangement where the NP just had a pad of signed prescription slips signed by the physician. So there's so much going on within these arrangements that it's difficult to categorize it just by whether the state allows full prescriptive authority or not. So that's the long answer. So the shorter answer is yes, we considered it, and the long answer is for a variety of reasons, it didn't show up as significant in any of our analyses.
I'm sure that's a surprise to a lot of people. That answer, the last part of your answer, but the more detailed information was very useful. I think people also understand it. We have time for one last question. It's a short one, and I know you can answer this one as well. But then we're going to have to, answer it very quickly. Oh, no. Anyway, but then we're going to have to get off. We're under a strict time limit. But the last question, Kate, and again, thank you very much for joining us. And boy, we have a lot of questions still out there. So you really touched a lot of interest in our audience. The last question is, you mentioned the CMS, what does that say? The CMS, data analysis. Do you have plans to analyze the cost and quality of care going forward?
Yes, we do. We actually have already done a lot of the work on cost, and we have a paper that's under review at Health Services Research. And I can give you a quick thumbnail sketch of what's in that paper. We assigned beneficiaries to NPs and MDs based on a very well-regarded patient assignment method. And what we found is that the NP assigned patients, even after adjusting for disease burden and demographic characteristics and propensity to see an NP, were less costly than the MD assigned beneficiaries. And there's a lot of data in the paper, and we hope it will be coming out. Soon. And then for the quality work, we've really just gotten started on that. So we're right in the middle of figuring out which outcomes are possible to look at using Medicare claims. So that work is ongoing, and I don't expect we'll have any results from that probably until the beginning of next year.
Okay, thank you, Kate. It's interesting. A couple of people were wondering about that. So this is good to know people are thinking beyond just what you've reported here today. All right. So with that, let me again say thank you very much, Kate. Thank you for all of the people who are participating on our webinar and have sent in their questions. I apologize we couldn't get to all of them, but stay tuned. Christy will be out with some information fairly soon about our next webinar, the timing for that. And in the meantime, I hope springtime has arrived wherever you are listening from, and that we've made it through winter. So thanks very much, and we'll be in touch soon.
Great. Thank you.
Thank you.